The Hospital Murders. A. Frank Murray Investigation. Season 2, Episode 2. Narrated by Frank Murray, private investigator. Death is supposed to be peaceful in a hospital. Clean, expected, surrounded by medical professionals who do everything they can to prevent it. But sometimes death walks the halls in a white coat, carrying a clipboard, looking exactly like someone who's there to save lives instead of ending them. The name's Frank Murray, and I've been working as a private investigator for 16 years. I've seen murder dressed up as accidents, suicides, natural causes. But I'd never investigated a hospital before. Never thought about how easy it would be to kill someone in a place designed to heal them. That changed when Dr. James Richardson walked into Murray and Murray Investigations. It was a Wednesday morning, 2 weeks after we closed the inheritance trap case. Sarah and I were catching up on paperwork, the unglamorous part being a PI that nobody talks about, when our newest client arrived. Dr. Richardson was in his early 50s, chief medical examiner for St. Catherine's Hospital on the west side. He had the exhausted look of someone who'd spent too many nights studying autopsy reports and seeing patterns nobody else wanted to acknowledge. "Mr. and Mrs. Murray," he said, sitting down without invitation, "I need your help with something that's going to sound insane. But I've checked and rechecked the data, and I'm certain I'm right. Someone at St. Catherine's is murdering patients." Sarah and I exchanged glances. Hospital murders were notoriously difficult to investigate. Too many variables, too much legitimate death, too easy to hide murder among natural causes. "Tell us everything," I said. Dr. Richardson pulled out a thick file folder and spread documents across our desk. Medical charts, death certificates, autopsy reports. St. Catherine's is a mid-sized hospital, about 300 beds. We average 50 deaths per month, mostly elderly patients, terminal conditions, end-of-life care. Normal for a hospital our size. "But something changed," Sarah prompted. 6 months ago, the death rate started climbing. Slowly at first, a few extra deaths per month. I attributed it to bad luck, seasonal variation, random chance. But over the last 6 months, we've had 98 deaths. That's nearly double our normal rate. Could there be a medical explanation? Disease outbreak, quality of care issues? I checked. No outbreak. No change in patient demographics. No drop in care quality. The deaths are spread across different departments. ICU, oncology, cardiac care, general medicine. Different ages, different conditions, different attending physicians. The only pattern is that they're all listed as natural causes or expected outcomes. So, what makes you think it's murder? Dr. Richardson pulled out another document, a spreadsheet with highlighted entries. I started looking at the specific circumstances of death. Most hospital deaths follow predictable patterns. Terminal patients declining gradually, cardiac events during surgery, complications from existing conditions. But these 98 deaths have anomalies. He pointed to highlighted sections. Patients who were stable suddenly coding. Medications that stopped working without explanation. Lab results that didn't match clinical presentations. Individually, each death makes sense. Collectively, there's a pattern that suggests intervention. Someone causing the deaths intentionally. Exactly. But here's what makes it impossible to prove. Whoever's doing this is sophisticated. They're choosing patients who are already sick, already expected to die eventually. They're using methods that mimic natural progression. And they're spacing out the deaths enough that no single doctor or nurse sees a pattern. "Except you," Sarah said, "because I see all the death certificates. I'm the only one with a comprehensive view. And when I raised concerns with hospital administration, they dismissed me, said I was imagining patterns, that hospitals deal with death constantly, that I was experiencing burnout. You think they're covering it up? I think they don't want to believe it. Admitting we have a serial killer on staff would destroy the hospital's reputation, trigger lawsuits, cause panic. It's easier to dismiss the medical examiner as paranoid than face the reality that someone's been murdering patients for 6 months. I studied the spreadsheet. 98 deaths. If Dr. Richardson was right, that was the highest body count I'd ever encountered. And the killer was still active, still working at St. Catherine's, still claiming victims. What do you want us to do? Investigate. Find proof. Identify the killer before they claim victim number 99. Dr. Richardson's voice cracked. I became a doctor to save lives. Watching someone murder patients while I'm powerless to stop them is destroying me. Please, help me catch this person. Sarah and I spent the rest of the day reviewing Dr. Richardson's data. The deaths were spread across 6 months, involving dozens of different medical staff, with no obvious connection except the statistical anomaly of too many deaths happening too close together. This is going to be nearly impossible to investigate, Sarah said, scrolling through medical charts on her laptop. We're not doctors. We can't just walk into a hospital and start questioning medical decisions. No, but we can investigate the staff. Look for anyone with motive, opportunity, and access to vulnerable patients. That describes literally everyone who works at a hospital. Then we narrow it down. We find the common factors, which staff members were present for the most deaths, who had access to medications or equipment, who benefits from patients dying. I called Miles Danforth, our tech expert. Miles, I need you to hack into St. Catherine's hospital records. Staff schedules, patient deaths, medication logs, everything. Frank, hospital systems are heavily secured. HIPAA violations carry serious federal penalties. People are dying, Miles. Someone's murdering them. We need the data. Miles sighed. I'll be careful. Give me 2 days. While Miles worked his magic, Sarah and I went to St. Catherine's Hospital undercover. We posed as concerned family members visiting a fictional relative, using the opportunity to observe the facility and staff. The hospital was standard mid-size, clean but not luxurious, busy but not chaotic, the kind of place that served its community competently without being remarkable. Staff moved through halls with practiced efficiency. Doctors consulted in quiet corners. Nurses managed care with professional detachment. Nothing obviously suspicious. Just a normal hospital, doing normal hospital things. But somewhere in this building, someone was killing patients. We observed the ICU, where many of the suspicious deaths had occurred. It was a secured unit. You needed badge access to enter, and visitors were strictly monitored. The nursing station offered clear views of all patient rooms through glass walls. Security cameras covered every angle. How does someone commit murder in a place that's monitored? Sarah whispered as we pretended to visit the cafeteria. By making it look like exactly what's supposed to happen. Patients die in ICUs all the time. If you know how to mimic natural death, who's going to question it? That's when I saw her, a nurse in her early 40s, moving between patient rooms with calm efficiency. She checked an IV, adjusted medication pumps, reviewed charts. Nothing unusual, except something about her movement pattern caught my attention. She was present in 6 different patient rooms during our 30-minute observation. That seemed like a lot of patients for one nurse. I took her photo discreetly with my phone. Miles called 2 days later with his findings. Frank, I'm in St. Catherine's system. I've got staff schedules, patient records, medication logs, security footage timestamps, cross-referencing everything against the 98 suspicious deaths. What did you find? The deaths cluster around specific shifts. Night shift has the highest concentration. 62 of the 98 deaths occur between 11 p.m. and 7 a.m., which makes sense. Fewer staff, less supervision, more opportunity. Who works night shift in the units where deaths occurred? That's where it gets complicated. Night shift rotates, so different staff work different nights. But I found 4 individuals who were working during more than 30 of the 98 deaths. That's statistically significant. Give me names. Nurse Catherine Porter, 42 years old, works ICU night shift. She was present for 38 deaths. Dr. Michael Stevens, 51, overnight attending physician, present for 35 deaths. Nurse practitioner Lisa Chun, 38, floating between units, present for 33 deaths. And respiratory therapist David Martinez, 45, present for 31 deaths. For suspects, all with access to dying patients, all working nights when supervision was minimal, all present for roughly a third of the suspicious deaths. Can you narrow it down further? I'm analyzing medication logs now. If someone's using drugs to kill patients, there should be patterns, medications administered shortly before death, Doses that don't match doctor's orders. Unusual drug combinations. Give me another day. After Miles hung up, I showed Sarah the photo I'd taken of Nurse Catherine Porter. She's our top suspect statistically. Present for 38 of 98 deaths. Or she's just an ICU nurse who works a lot of night shifts and sees a lot of death. Frank, correlation isn't causation. I know, but it's a starting point. We dug into Catherine Porter's background. 42 years old, divorced, no children, worked at St. Catherine's for 12 years. Clean record, no disciplinary actions, multiple commendations for excellent patient care. She volunteered at a hospice on her days off, participated in hospital committees, was well-liked by colleagues. On paper, she looked like the exact opposite of a serial killer. People who kill for mercy sometimes have profiles like this, Sarah said, reading through Porter's evaluations. Compassionate, dedicated to end-of-life care, genuinely believes they're helping patients avoid suffering. You think this is mercy killing? It fits. Someone who works in ICU, sees terrible suffering every day, might convince themselves that hastening death is kindness. They choose patients who are terminal anyway, use methods that appear natural, and genuinely believe they're doing good. If that's true, Porter's our killer. She works hospice. She's in ICU where the sickest patients are. She's present for the most deaths. But we needed proof, and getting proof meant catching her in the act. Dr. Richardson called us the next morning, his voice tight with stress. Another death last night. Patient in ICU, 78-year-old woman with advanced heart failure. She'd been stable, expected to live another few weeks at least. Coded at 3 a.m., couldn't be resuscitated. Who was on duty? Night shift. Catherine Porter was her nurse. That made 39 deaths with Porter present. The pattern was becoming undeniable. Dr. Richardson, I need you to do something for me. Order a comprehensive toxicology panel on the patient who died last night. Test for everything, all medications, drugs that wouldn't normally be tested, anything that could cause cardiac arrest. The hospital won't authorize that expense without cause. Then do it quietly, out of your own budget if necessary. If Porter's using drugs to kill patients, we need to find evidence. 3 days later, Dr. Richardson called with the results. You were right. The toxicology panel found traces of potassium chloride in the patient's system, significantly elevated levels, enough to cause cardiac arrest. Potassium chloride is used medically, right? In controlled doses, yes. It's part of normal IV solutions. But in large doses administered rapidly, it stops the heart. It's nearly impossible to detect post-mortem because potassium naturally increases after death. You'd only find it if you tested immediately and knew what to look for, which is why Porter chose it. It mimics natural cardiac arrest, leaves minimal evidence, and wouldn't be questioned in a patient with existing heart problems. Mr. Murray, this is murder. We have proof. We need to go to the police. Not yet. One toxicology result isn't enough to prove serial murder. We need to establish pattern, motive, and opportunity. We need to catch Porter in the act or get her to confess. How do we do that? We set a trap. The plan was simple but dangerous. We'd identify a vulnerable patient, someone terminal, someone expected to die soon, someone Porter would see as a candidate for mercy. Then we'd monitor that patient around the clock, waiting for Porter to make her move. Dr. Richardson identified the candidate, Harold Chun, 74 years old, end-stage lung cancer, DNR order in place, expected to live days to weeks. He was conscious, coherent, and when Dr. Richardson explained the situation, agreed to help. If I can help catch someone who's been killing patients, that's a better legacy than just dying of cancer. Harold said weakly from his hospital bed, use me as bait. We set up surveillance in Harold's room. Hidden cameras that Miles installed, monitoring equipment that would alert us to any changes in vital signs, and Sarah or me physically present in rotating shifts, disguised as family members keeping vigil. For 3 nights, nothing happened. Porter worked her shifts, checked on Harold periodically, administered his prescribed medications, and moved on to other patients. Professional, compassionate, showing no signs of being a killer. On the 4th night, Harold's condition deteriorated. His breathing became labored. His pain increased. Porter came in at 2 a.m. to check on him. I was in the room, pretending to doze in a chair, watching everything through half-closed eyes. Porter checked Harold's vitals, adjusted his morphine drip to ease his pain, and held his hand while speaking softly. "You're suffering, Mr. Chun. I can see it. Your family doesn't understand how much pain you're in. But I do. I see it every day. And I know how to help." She pulled out a syringe from her pocket, not from the medication cart, from her personal pocket. "This will help you sleep, help you find peace. No more pain, no more struggling to breathe. Just peace." She was preparing to inject it into Harold's IV line when I stood up, step away from the patient, Nurse Porter. Porter froze, the syringe in her hand, her face draining of color. "Who are you?" "Frank Murray, private investigator. That syringe contains potassium chloride, doesn't it? The same drug you've used to kill 38 other patients over the last 6 months. I don't know what you're talking about. This is just medication. We have cameras recording everything. We heard your confession. And we have toxicology results from your previous victims proving you've been administering lethal doses." Sarah entered the room then, her detective badge visible, along with 2 uniformed officers Dr. Richardson had stationed nearby. "Catherine Porter," Sarah said formally, "you're under arrest for the murder of 38 patients at St. Catherine's Hospital." Porter looked at the syringe in her hand, at Harold Chun lying in the bed, still breathing, at all of us surrounding her. Then something in her expression shifted, from shock to resignation to something almost like relief. "They were suffering," she said quietly. "All of them. Terminal patients in pain. Families forcing them to keep fighting when there was no hope. I gave them peace. I gave them dignity. I gave them what they wanted but were too afraid to ask for. You gave them murder. I said, I gave them mercy." Porter set down the syringe. 38 people who would have died anyway, who would have suffered for weeks or months, who begged me with their eyes to end it. I helped them. That's not murder. That's compassion. "Did they consent?" Sarah asked. "Did any of them ask you directly to kill them?" Porter was silent. "That's the difference between mercy and murder," Sarah continued. "You made the choice for them. You decided their lives weren't worth living, that their suffering justified death. You played God, Nurse Porter. And God doesn't belong in a hospital deciding who lives and who dies." The arrest of Catherine Porter made national news. "Angel of Death," headlines screamed across newspapers and websites. St. Catherine's Hospital issued statements about cooperating with investigations and ensuring patient safety. Families of the 38 victims filed lawsuits. And Catherine Porter, in custody awaiting trial, maintained she'd done nothing wrong. "I'm a nurse," she told investigators during interrogation, which Sarah and I observed through one-way glass. "For 20 years, I've watched people suffer. Cancer patients screaming in pain. Alzheimer's patients who don't recognize their own children. People on ventilators who will never breathe on their own again. And I'm supposed to just let them suffer because that's life? That's cruel. What I did was mercy." "You killed 38 people," the interrogating detective said. "I ended 38 cases of pointless suffering. There's a difference. Did any of them ask you to kill them?" "They couldn't ask. They were too sick, too weak, too scared. But I could see it in their eyes. I could see them begging for release. That's not consent, Miss Porter. That's compassion. Something the medical system doesn't understand anymore. We keep people alive long past the point of meaningful existence, tube them and medicate them, and prolong suffering, because we're too afraid of death to let people go peacefully. I gave them what the system wouldn't, a gentle exit. I watched Porter through the glass and felt something I didn't expect. Not satisfaction at catching a killer, but sadness, because part of what she said was true. The medical system does prolong suffering sometimes. End-of-life care is complicated, messy, involves impossible choices between quality and quantity of life. But Porter had made herself judge, jury, and executioner. She decided 38 times that someone else's life wasn't worth living. And that was murder, no matter how she rationalized it. The trial took 4 months. Porter's lawyers argued mercy killing, diminished capacity, burnout from years of witnessing suffering. The prosecution presented toxicology evidence, testimony from families who never consented to their loved ones being killed, and expert witnesses explaining that what Porter did was murder, not mercy. Dr. Richardson testified about discovering the pattern, about how Porter had chosen vulnerable patients and used methods designed to avoid detection. Harold Chen testified about Porter's attempted murder in his hospital room, about hearing her confession on the hidden camera footage. The jury deliberated for 3 days. Catherine Porter was found guilty on 38 counts of first-degree murder, sentenced to life without possibility of parole. As they led her from the courtroom, she looked directly at me. "You think you did something noble. Caught a killer, saved lives. But, Mr. Murray, those people I helped, they're still dead. They died in pain, in fear, suffering until the very end, because you stopped me from giving them peace. You didn't save anyone. You just ensured more suffering." Her words haunted me for weeks after. Sarah found me in our office one evening, staring at the case file, unable to shake Porter's accusation. "You're thinking about what she said," Sarah observed, sitting beside me. "Am I wrong? Do we do the right thing?" "Frank, she killed 38 people without their consent. That's murder. But what if she's right about the suffering? What if those patients were in agony? What if their families were forcing them to endure pain for selfish reasons? What if Porter really was ending suffering? Then she should have worked within the system, advocated for better palliative care, for stronger right-to-die laws, for patients to have more control over their end-of-life choices. She didn't do that. She took it upon herself to decide who lived and died. That's not compassion, Frank. That's playing God. But the system is broken. You've seen it. People kept alive on machines, unable to communicate, suffering because families can't let go or insurance companies won't pay for hospice care. Porter saw that brokenness every day. So have millions of other healthcare workers. They don't become serial killers. They advocate. They push for change. They provide the best care they can within ethical boundaries. Porter crossed those boundaries. She became what she claimed to oppose, someone who valued her own judgment over patient autonomy. Sarah took my hand. "I know this case is different. It's not clean. There's no clear good guy and bad guy. Porter genuinely believed she was helping. But belief doesn't justify murder. And if we allow medical professionals to kill patients based on their personal assessment of suffering, where does it end? Who decides which lives are worth living? Who gets to play God?" "No one," I said quietly. "Exactly. That's why we caught her. Not because what she did lacked compassion, but because what she did denied those patients their fundamental right to make their own choices about life and death." I sat with that for a long time. Sarah was right. The case wasn't satisfying like catching a robbery-motivated killer or a revenge-driven murderer. This was murky, complicated, existing in the gray area between mercy and murder. But gray area or not, Catherine Porter had killed 38 people without their consent, and that made her a murderer, regardless of her intentions. Dr. Richardson came to our office a week after the trial ended. "I wanted to thank you personally," he said. "Because of your investigation, St. Catherine's has implemented new protocols, better monitoring of medication administration, random audits of patient deaths, psychological evaluations for staff working in high-stress units. We're making sure this never happens again." "How are you doing?" I asked. This couldn't have been easy, exposing a colleague as a serial killer. It wasn't, but it was necessary. I became a medical examiner because I believe in truth, in finding answers when others are content with assumptions. Catherine Porter's victims deserve the truth. Their families deserve justice. Dr. Richardson paused. "I've been thinking about what she said at trial, about suffering and mercy and the system being broken. She wasn't entirely wrong." "No," I agreed. She wasn't. So I'm working on that now, advocating for better end-of-life care, pushing for expanded hospice access, consulting with ethicists about patient autonomy in terminal situations. If I can honor those 38 victims by helping improve the system that failed them, maybe their deaths can mean something. After Dr. Richardson left, Sarah and I sat in our office and reflected on the case. 12 saves now. Sarah said suddenly. What? I've saved your life 12 times. The hospital case makes 12. Remember when you were setting up the surveillance in Harold Chen's room? That orderly who came in unexpectedly and you thought was security threat? I distracted him before things escalated. That wasn't a life-threatening situation. You had your hand on your gun. He was a 200-pound former Marine working security. If things had gone wrong, you could have been hurt. That counts. You're very generous with your counting. I'm very invested in keeping you alive. She kissed my forehead. 12 saves and counting. At this rate, I'll hit 20 by the end of the season. Let's aim for fewer near-death experiences, says the man who used a cancer patient as bait to catch a serial killer. Fair point. We close the case file on Catherine Porter. 38 victims. 1 killer. Justice served. Even if it didn't feel entirely satisfying. The phone rang with our next case. Someone with a problem. Someone who needed help. I answered on the second ring. Murray and Murray Investigations. Frank Murray speaking. Mr. Murray, my name is Rebecca Walsh. My father died 3 weeks ago in what police are calling an accidental drowning. But I don't think it was an accident. I think someone murdered him and made it look like he fell off his boat. Can you help me? I grabbed a pen and paper. Tell me everything. Because that's what we do. We investigate when others stop looking. We find truth in the gray areas. We catch killers, even the ones who believe they're doing good. The name's Frank Murray. I'm a private investigator working with my wife, Sarah Murray. We've solved 12 major cases now. 2 in Season 2, 10 in Season 1. We face mercy killers, inheritance conspiracies, corrupt politicians, and our own personal demons. I'm not rich. I'm not famous. Most of our cases still involve routine investigations. But sometimes, just sometimes, we get to stop a serial killer who's been murdering hospital patients for 6 months. We get to bring justice to 38 victims whose families thought they died naturally. We get to prove that even in the complicated gray areas of medical ethics and end-of-life care, murder is still murder. And we do it together. Because Sarah's right. I need someone to keep me alive through all the dangerous situations this job brings. And she needs someone stubborn enough to see cases through even when the answers aren't satisfying. This is Season 2, Episode 2, and we're just getting started. If you enjoyed this story, please subscribe, and ring the bell for notifications. Murray and Murray Investigations continues with more complex cases, moral gray areas, and the kind of investigations that don't have clean answers. From inheritance traps to hospital murders to whatever comes next, we take on the cases that matter. Thanks for listening, and we'll see you in the next investigation.